So while we wait for more people to join us, I'll just tell everybody a bit about the format for this evening and do some introductions. So this evening we have an hour together, and I'm absolutely delighted to be chairing. My name's Lucy Jones. I'm the VP Clinical at Oviva, and my background is as a specialist dietitian. And I'm really, really delighted to be hosting our webinar this evening. We have some fantastic speakers for you, and it's going to be a really interesting opportunity to find out more about using different dietary approaches in type 2 diabetes. So for the format for this evening, I'm going to introduce our panel of speakers. We'll go into a bit of a roundtable discussion with those, and that will take up around 40 to 45 minutes of our time together. And I'll try and save a section at the end to take some questions from the audience. So feel free to add questions through the talk this evening. Any questions that we don't get round to, what we'll do is we'll make sure that we send a response to those written. So we are going to be recording this evening's webinar, and we'll try and make that available to everybody who's registered by Monday, and we'll include a response and some more visuals and information on the trial when we send that out, and we'll try and make sure that everybody's questions are answered. So without further ado, our topic this evening is the Midas trial. So that has just been presented over at the European Association for the Study of Diabetes conference. And we wanted to take the opportunity to actually share the results more widely with everybody locally who was interested before they actually go in for final publication. So I am joined here this evening by Dr. Basil Issa. He's our co-CI for the Midas study, and he's a consultant endocrinologist at the Manchester University Foundation Trust. So he underwent his training in Manchester, Southampton and Cardiff, where he completed his doctorate degree. Basil's worked as a consultant in the NHS and privately for over 22 years, and he has a wide-ranging experience in all aspects of endocrinology and diabetes. He led the obesity services at the North Manchester Hospital, and he ran a busy obesity clinic and a very low-calorie diet service. His research interests include low-calorie diets and adrenal disease, and he has a number of publications in peer-reviewed journals and abstracts published in proceedings of national and international meetings. I'm also joined by Dr. Michelle Harvey. She is a research dietitian at the Prevent Breast Cancer Unit at Manchester University Hospital's NHS Trust, and she's been there since 2001. Her research involves testing low-calorie diets, including pioneering intermittent low-calorie IV diets. This is primarily focused on the prevention and management of cancer, which has evolved and extended to the management of diabetes. She's had 74 peer-reviewed publications, including 12 trials and reviews concerning intermittent diets. She's published a variety of books, and all of her author proceeds go to the Prevent Breast Cancer Unit. We're also joined by Sarah Mcdermott. So Sarah Mcdermott is a diabetes dietitian and a research dietitian over at the Manchester University NHS Foundation Trust, and her current research is focused on the role of intermittent and continuous low-calorie diets in type 2 and type 1 diabetes. Sarah has NHS and private sector experience in specialist weight management, gastroenterology and cardiovascular disease. And prior to becoming a dietitian, Sarah worked for several years in government and the NHS, analysing and reporting on national health and nutrition-related data. And our final speaker for the evening is Lucy Diamond, who's our head of clinical at Aviva UK. She's an award-winning, experienced diabetes specialist dietitian, having worked for over a decade within the NHS at King's College London. Her current role as the head of clinical at Aviva combines management and leadership with research-based practice, and she takes the lead in developing and evaluating the evidence-based diabetes, structured education, prevention and remission programs, whilst continuing her clinical practice and managing the care quality of the team delivering the Aviva diabetes programs. So, without further ado, let's plough on into our roundtable. So my initial plan had been to come to Lucy Diamond, and this is probably a very good opportunity to explain to all of our audience that we are live So please bear with us if there's any tech challenges. We're all living in this world where we have to dial in remotely, as you'll all be used to too. And there's always the potential for people's internet to drop out. So if I do lose any of our speakers at any point, they will try and dial in using their phone connections, and you may not be able to see them. So let me just check. Have we got Lucy with us, or has she dropped out for a moment?
Yeah, no, I'm here. I'm hiding. I promise I am on the line, but I'm trying to just get back on visually. But I am connected for you to be able to hear me.
Wonderful. We can hear you loud and clear. Thanks so much, Lucy.
Perfect.
So I'd actually like to come to you first and get you to tell us a bit more about why this project and the research was of interest to Oviva.
Yeah, absolutely. Thank you, Lucy, and welcome to everybody on the line this evening. So to give a bit of background, Oviva has been running diabetes education and behaviour change courses within the NHS since 2016. So throughout our time, we have been keeping a really close eye on the development of any progress and research within the field of type 2 diabetes. And as many of you on the line will be aware, in recent years, we've really seen the success of the use of low-calorie diets, LCDs, in diabetes remission through the studies of direct and droplets. So both of these studies were delivered face-to-face. And over the years at Oviva, we've been building evidence and insight to show that actually digital offerings can really widen access, particularly in hard-to-reach groups, greatly improve uptake and engagement, and at a lower cost. So when we heard about this opportunity to work with the Manchester University team to explore the remote offering of LCD within type 2 diabetes, we're really excited. But not only about exploring LCD in digital, but looking at an area that's not yet been researched. So comparing and looking at, could an LCD in an intermittent form be a more acceptable offering for participants? And at that stage, Lucy, I'll hand you back.
There you go. Tech challenges all round. Thank you very much, Lucy. That was a really useful intro. And following on from that, what I'd like to do actually is take our background and why we were interested in that, and to go over to Michelle to explain a little bit more about what you identified as the gaps in the evidence base and knowledge, and what you hoped to achieve by undertaking this trial.
Thank you, Lucy. So as you've just heard, so we know that, these low-calorie diets can be done and have been shown to be very successful. So the direct study had, nearly 50% of the patients losing 10% of their weight and 46% going into remission at the end of the first year. And, with 36% maintaining that out to 2 years. But of course, if you read the detail, these patients were in a very intensive face-to-face program with 35 face-to-face appointments, very onerous, and particularly, now with COVID, that's just not going to happen. And there was, the diets were successful, but, about 50% of the patients were actually doing the diets. If you look at it, there was dropout, there was weight regain. And obviously we know with any intervention, particularly diets, one size does not fit all. So while obviously that approach does work, we wanted to think about other ways of doing it. And as you've already heard, we've got a big interest in intermittent diets in Manchester. And so we wanted to combine the idea of looking at the remote delivery of these programs with also whether or not, rather than doing your 10 weeks of daily low-calorie diet, or actually in this case we did 8 weeks, whether we could just do 2 days a week and extend the same number of low-calorie days over a longer period. And would people find that more acceptable? Would they be more likely to sign up for it? Would they be more likely to do it? And ultimately, importantly, what were the likely effects of that on their weight and their HbA1c and their diabetes? So the MIDAS study, which is the Manchester Intermittent Diabetes app study, we started, and it's a feasibility study. So it's really trying to look at the uptake to either a continuous or intermittent program, the retention of patients as they go through the year programs, and to get an idea of a signal that maybe they might be effective for weight loss and reducing HbA1c. So we included obviously patients with type 2 diabetes, and we wanted to be a bit more inclusive than some of the previous trials, and we allowed patients who were up to 8 years within a diagnosis of diabetes. We allowed patients who are up to the age of 75, and we also included quite a number of patients with moderate psychological morbidities that might normally get excluded from trials. Obviously, we included men and women. And they had to have an HbA1c of at least 27, unless they were from a high-risk ethnic group when it was 25. So it was a year-long study with the idea of looking at the feasibility of these diets.
Thanks, Michelle. I'm just going to correct you. It was a BMI of 27, not an HbA1c of 27.
Thank you.
Too low. No worries.
Sorry.
I knew what you meant. I knew what you meant.
Do apologise.
No worries. And of course, the other
Michelle,
thing that you... Yeah, go ahead, Basil.
Sorry, and 10% of our patients were on insulin.
They were. Thank you.
Yeah,
yes.
Yeah. So that's also quite an important point to make, because these were patients on insulin were excluded from the direct study.
Absolutely.
So quite a lot of nuances about this patient group that perhaps hadn't been tested before, and we were using a new intervention. So we knew that there is, a good chance that low-calorie diets were going to be have a level of success in achieving this, but the intermittent angle was much more novel. And I guess the other element that perhaps the Midas trial brought in that we haven't touched on yet is the fact that much of the care wasn't face-to-face. So I'd be very interested to hear, Michelle, your thoughts on why that was an interesting element to bring into this, and on what you had hoped it would bring.
So actually in Manchester, we've been doing remote delivery of interventions by phone for probably about 10 years before we started doing Midas, and I've always thought it was a good way. It's much easier for people to do that, and it works really well. You can create a rapport with people, and the patient group we're talking about here, even before COVID, life's much easier if you don't have to arrange appointments, have to pay for parking, try and find a parking space, all of that stuff. And I think you can, and also you can, particularly with the app, as we'll discuss as we go through, you can get more real-time feedback much quicker than when you're waiting for your sort of monthly appointment, when you're actually just lost in the ether. So I guess the remote stuff enables, it's easier. It's certainly easier to deliver from a lot of respects from the healthcare professional, but it's more importantly, it's easier for the participants to fit into their lives, and they get more rapid feedback, and probably more feedback, more frequent feedback, which is obviously key.
Yeah, so there's likely, or we were hoping to see an impact on uptake and retention, and potentially engagement as well. From what you're saying, people are getting more frequent interaction, and the hope is therefore that you can keep them engaged on dietary approaches that aren't always easy and come with their own challenges, and we need to find ways to actually really support patients through that to get a better adherence through. Yeah. So coming on to you, Sarah, what would be really useful is if you gave us an insight into what did the programme actually entail? How was it delivered by the clinical team?
Yeah, sure, no problem. So I'll start by talking a bit about the diets, first of all. 79 participants were on the trial. They were randomly allocated to the intermittent or continuous low-energy diets. So each program had an active weight loss phase and a weight maintenance or continued weight loss phase. Participants were encouraged to continue losing weight until they'd achieve 15% weight loss or more. The two diets were isoenergetic, so similar calorie sort of restrictions in the active weight loss phase, so we could compare them. They both included 56 low-calorie days. The active weight loss phase of the continuous group, which is like the direct trial, lasted 12 weeks and involved the OptiFast 800-calorie diet. That's 3 shakes or soups plus 7 portions of non-starchy veg plus lots of calorie-free fluids, 7 days a week for 8 weeks, and then followed by 4 weeks of stepped food reintroduction. The continuous group then moved on to 40 weeks of a portion-controlled Mediterranean diets over the rest of the year. And then the active weight loss phase of the intermittent group, well, that involved the 800-calorie diet 2 days a week and a portion-controlled Mediterranean diet 5 days a week for 28 weeks. The intermittent group then moved on to do 1 or 2 days of a food-based version of the low-calorie diet, depending on whether they wanted to maintain or continue losing weight. So participants were also offered a one-off relapse program. So if they gained 2 kilograms or more in the weight maintenance phase, so after they'd done their low-calorie days, they could return to, if they were in the continuous group, their continuous low-calorie diet for just 1 week, which is a lot shorter than in the direct program, or the intermittent diet, low-calorie diet for 1 month. So that's a bit of information about the diets themselves. Now the support on the trial. So a really important feature, as you've all been talking about on this study, was the high frequency remote support provided by the Aviva app or by telephone. So this was delivered by a multidisciplinary team, including dietitians, a nurse, an exercise specialist, and a psychologist as well, delivered to both groups equally. The dietitian, for example, the contact was weekly in the first 3 months. That coincided with the active weight loss phase of the continuous group, then fortnightly in the second 3 months, and then monthly in the final 6 months. Eligibility for support from the trial psychologist. That was determined by scores on validated questionnaires assessing things like depression, anxiety, self-efficacy, binge eating. Psychology support was available for the first 12 weeks, that intensive phase, particularly for the continuous group. That was important. But the app itself, that enabled messaging, logging of food, photos, weight, blood glucose, and exercise as well. So that's a bit of information about the diet and the support that was provided.
Thanks, Sarah. That was really useful. Just coming back to you, Michelle, you were saying about the different types of patients that were included. So we understand that insulin patients were included, wide range of HbA1cs, wide range of weights. Can you run us through who wasn't included, who was excluded, who did we not take on as part of this trial? So
we excluded patients with a BMI greater than 50 because we felt they possibly could, were more sort of bariatric or had more complex needs that we couldn't meet. Obviously, we excluded people who might be pregnant or think they were planning to get pregnant, and people with severe psychological problems and active eating disorders at the time, or very severe depression or alcohol issues. Again, as Sarah says, based on the screening questions. People with other sort of current comorbidities that we felt might be, be made worse by the diets, and people with low self-efficacy as well. People that just were really not in a good place to try and diet. I think those were the main ones. Sarah, Basil, can you think of some?
Yeah, so we
the
also
other comorbidities. Sorry, carry on, Sarah. Carry on.
So a HbA1c over 108 as well. So very, very high HbA1cs, and Basil can talk a bit more about that as to why. Obviously, prior weight loss surgery as well. We did have a few people come forward who had had weight loss surgery previously who wanted to try the study, but they were excluded as well. So over to you, Basil.
Yeah, so Sarah mentioned the high HbA1c, and we excluded them simply because we felt that they needed more urgent intervention, and it would be unethical really to leave them between inverted commas untreated and put them in a clinical trial. So they needed urgent intervention. And then we excluded patients, as Michelle was saying, with other comorbidities such as heart failure, severe heart failure, or renal failure, or active cancer. So these are the other medical conditions which, in the opinion of myself as principal investigator, deemed them unsuitable to participate in the study.
Thanks, Basil. And keeping you on, let's just jump on. Can you take us to the meaty bit? What were the key results of the trial? And give us your thoughts on them too.
Okay, so as Michelle said, this was a feasibility study. So just to go through the outcome measures that we wanted to look at is one was the recruitment and the retention in the study. There was a primary outcome of achieving weight loss of 15% or more. And the third primary outcome was achieving an HbA1c of less than 48. And then there were a number of secondary outcomes, including adherence and the uptake of using the Aviva app, and also other secondary outcomes, including body composition, etc. So in terms of recruitment, we've recruited approximately 30... So approximately half of our patients, 37%, sorry, of our patients, so apologies, 46% of our patients from primary care and 37% of our patients from a secondary care hospital clinic, and then 13% from, we used patient registers, so registers where patients put their names to be included into clinical trials. And then there was about 5% who came from just word of mouth and other sources. In terms of the uptake, in primary care, the uptake was about 35%, and in secondary care, it was approximately 20%. And our retention rates were approximately 70% in the intermittent group and 75% in the continuous group. Now, in terms of weight loss, as expected, the weight loss was much more in the continuous group in the first 12 weeks. So they were much more energy restricted than in the intermittent group. And they lost about 10% of their body weight in the first 12 weeks. Whereas if you compare the intermittent group, they lost about 6% of their weight. But by the end of the study, the two groups achieved more or less the same amount of weight loss. So 5.4% in the intermittent group and 6% in the continuous group. And if we look at the percentage of patients who achieved 10% weight loss, the two groups at the end of the study, and this is an intention to treat analysis, the two groups fared more or less equally. So in the intermittent group, about 20% achieved 10% or more of their of weight loss of their baseline body weight, and similarly 20% in the continuous group. And if we look at the number of patients who achieved 15% or more weight loss, it was 6% in the intermittent group versus 4% in the continuous group. Now, moving on to the HbA1c data, in both groups, 42% of the patients achieved an HbA1c of less than 48. So it was exactly the same number in both groups. But it's important to mention that in the intermittent group, there were more patients or more participants on medication as compared to the continuous group. And we assessed that by looking at their medication effect score. So the medication effect score, for those of you who don't know what it is, it's a formula, and that tells us, or it reflects, how much diabetes medication the patient is taking. In terms of the secondary outcomes, the adherence to low energy days during the active weight loss in each group was excellent. It was about 80% in the intermittent group and 90% in the continuous group. And then in terms of the uptake to the Oviva app, that was also excellent. 90% uptake to the Oviva app. And halfway through the study, we set up a group forum where we joined people with their consent, of course, people together in a forum to support each other, and 50% agreed to participate in the group forum. So, I mean, whereas we can't really draw a huge amount of conclusions from this study because it's a feasibility study, nonetheless, I think the study shows us that there is an alternative here to continuous diet. We've got some very good evidence for the continuous diet with the direct study and the droplet studies which have been mentioned. But the intermittent diet is a very good alternative. And we know that when we're dealing with a group of people with type 2 diabetes, where overweight and obesity is very rife, one size does not fit all, and we need to have a number of tools in our toolbox to be able to help these patients. And number two, as was mentioned before, the remote support worked very well in this study.
Thank you, Basil. That was really useful. I think it's also worth mentioning, just to be very favourable on your results, is the percentage with an HbA1c below 48 was also an ITT analysis. So if you looked at the percentage achieving that within the patients who did complete, actually it was quite a lot higher, wasn't it? It was more around the 50%. That's
correct. Yes. Yeah. This was the intention to treat that I've put the data forward.
Like a true researcher. Yeah. Yeah. So, you know, for those that continue to engage, really impressive outcomes on the HbA1c. Now, I know a lot of people watching will be quite familiar with the results from Direct and may do a like-for-like comparison on the weight loss front. And of course, there are some differences there. And I think it would be really good for us to bring out what some of the differences were in the intervention delivered to make sure that actually we're accounting for that. Lucy, would you like to hop in and just talk to us about what some of the differences were between what was delivered in Direct and what we delivered here in Midas?
Yeah, absolutely. And also to flag, and I think Michelle and Sarah will rightly so jump in with me in a second to talk through really about the patient care and the journey. But maybe if I can just give a bit more of an insight into the sum of the differences from delivery perspective. I'm not sure we'll really give the rationale for the differences in results, but I can also talk a little bit about some of the other studies that we've been involved in too that do mimic Direct and are seeing very similar results. So a digital program we're conducting as a pilot getting on board with our NHS LCD that I'm happy to speak about a bit later if there are questions on that and our involvement there, but has had similar weight loss of 15 kilograms at the 6-month mark and even 16 kilograms at the 12-month mark. I think when you look at the different interventions here, it's rightly so that Basil said, we know that the success of a continuous VLCD works beautifully. We've seen that with Direct, we've seen that with Droplet, and that is why the NHS pilot is very much focusing on this approach with NHS England at the moment. But I do think you're right, there is a cohort for that which that is not relevant, that is not a doable challenge to undertake. So I do think we need to look at what are the suites and tools we have available. When it came to the delivery model, we did have that intensive support. So very similarly, we had the intensive support, but also in that remote nature. So I think we have to then explore what other elements within the approach that maybe Sarah and Michelle would be able to allude to could answer some of the difference in outcomes that we're seeing compared to Direct. So I'm handing the bat over to maybe delve a bit deeper into why we think that was the case here.
Michelle, should we thank you for that?
So yeah, and I'm sure Sarah can chip in. So we only had 8 weeks of a continuous diet versus up to 20 in direct. So do your sums.
It's a huge difference, isn't it? Yeah,
it's a huge difference. And the other thing which Sarah is always reminding me about is that our relapse program probably wasn't really that it could have been better. So in direct, they could have the diet for up to a month, I think, and they could have numerous relapses. So if they regained weight, they could go back on the diet. We allowed the patients one relapse in the study design, and that was only a week. So there are huge differences. We also didn't put them on, weight loss medications. We started off with a more challenging population as well, but I think, and also the support. So we've accepted that the remote support works really well. However, I think Sarah again has made this point a huge number of times, that we were giving them remote support in the last 6 months of the intervention, but it was only monthly, wasn't it, Sarah? It was a monthly text.
Yeah, that's
so
right.
Again, we didn't really, we could have done more remote support. We didn't use. I mean, I started off this webinar talking about how remote support can enable you to do more frequent, and we didn't do that, and I guess we would in future.
Yeah, well, and that's what's so lovely to pull out the learnings and the beauty of having done a feasibility, because what we're able to see is that those diet approaches have worked wonders on reducing HbA1c and getting patients those benefits. And actually, what we can also pull out is the differences between what we delivered and what we've seen other interventions deliver. So we're able to then learn from it. And we know that actually having the flexibility to extend that low-calorie diet period initially can definitely help get you a greater weight loss. And we also know that being able to work flexibly around weight regain is going to be a key strategy to keeping that weight loss going to 12 months, to 24 months, to 36 months, and encouraging patients to do relapse intervals to bring their weight back down is going to be very helpful, so that you don't see that residual weight gain. And I think, we can take those learnings onto our next studies and make sure that they're included and drive actually that further weight loss that we want to see. Wonderful. So what I'd like to do from there is to go back to you, Sarah, and find out what the patients thought. So can you share some of the sort of insights and experiences that patients gave you about what it was like being on the Midas trial?
Yeah, sure. So very, very positive on the whole, massively positive. So we conducted a focus group with a small group of patients from the trial. We also interviewed, did a small sub-study. We haven't analysed those results yet, but there were some key themes there. So a real appreciation for the specialist advice that was offered from the whole team, very friendly, supportive, well-organised team. They commented that the standard of care provided was well above what they'd received previously. Obviously, even though it's not as frequent a contact as maybe as seen on direct, it was still above what they're used to receiving. And sadly, there was a bit of a sense of low confidence in their practice nurse or GP to manage their diabetes prior to starting the study, particularly around diet. So I think they really appreciated that specialist dietetic input. A key bit of feedback was around different levels of support. So we had a program of support where it was obviously more intensive at the start, and then it sort of dropped off towards the end of the trial. The view there was thinking, to help the patients become, self-managing of their diabetes. In actual fact, people wanted it the other way around. They actually found the low-energy diet, the 8-week low-energy diet, really quite straightforward. In fact, many people thrived on that break from food and that prescription almost that's given in those first 8 weeks. And they really needed more intensive support during the diet reintroduction phase, and then moving on into the weight maintenance and continued weight loss phase. So that's a definite point of reflection that we'll take forward. Also, another bit of feedback was really appreciated the psychology input on the trial. Many of the patients had never had any sort of psychology support before, and they thought that was very important, useful. People need that to really think about the barriers to potential weight loss at the beginning, before they're even starting out on these diets. And in terms of the app, that I found really interesting. The logging of their weight, their blood glucose and their blood pressure. It helped them made them accountable to the team, but also to themselves. And it really led to increased motivation as they could see what the changes they were making in terms of their diet, the impact that was having directly on their blood glucose, on their blood pressure. Every time a kilo came off, how the results were changing. That, I think, was a real asset with the app. And also, that ability to contact us so easily. It made it easier to sort of re-engage people just with a quick message. A telephone call or a face-to-face appointment is obviously a lot more time from people's lives. So I think the app was really helpful, and the patients were saying that to us as well. So I've got loads of feedback from patients, but there were some of the things that I've pulled out.
Those are great. So we have had a couple of questions come in directly on the sort of structure and the delivery, which I think, Sarah, you would be best placed to take. One of the questions was if you can just expand a bit on the Mediterranean diet that was used for the control on the intermittent fasting angle, and how that was created and what it looked like.
Yeah, okay. So many people will be familiar with the Mediterranean diet, so it's a high sort of fairly high protein diet, so 25% of energy from protein, moderate carbohydrate intake, about 45% energy, and then moderate fats, around about 30%. So it's quite high in unsaturated fats, like nuts and seeds, olive oil, avocados, lots of lean meats, oily fish for heart-healthy omega fats, and low in saturated fats like, from butter and red meat, plenty of vegetables, some fruit and low-fat dairy. So they're the sort of foods that we're encouraging as part of a Mediterranean diet. The way we delivered that, we calculated people's energy requirements for weight loss using our dietetic calculations that we do. We then reduced that by 25% to help people lose the weight, and then presented the diet in terms of food portions. So portions from the carbohydrate food group, proteins, fats, fruit, veg, and dairy. So they didn't really have to think about calories at all. It was all about meeting portions. Then we provided a lot of sort of meal ideas and some meal plans as well for them to use. So it was really quite flexible in terms of what foods, what meals they put together. They just had to meet these portions.
Fab. Another one on the diets I've seen come in. Can you tell us how you did the food reintroduction after the low-calorie diet?
Yeah, so that again was underpinned by the Mediterranean diet, but they had it's a 4-week process. 1,000 calories per day in the first week, 1,200 in the second, 1,400 in the third, and 1,500 in the fourth. The patients didn't know about the calories. Again, it was all delivered by these food portions, which I think is a really, really healthy way of getting people to sort of think about food. They were prescribed portions from each of these food groups. Again, lots of meal ideas. In future, I think one of the learning points is people might have benefited from more structured meal plans during this phase. We gave them the flexibility, but actually I think it's such a difficult phase. And I know on Direct they use partial meal replacements. In other words, people could replace one of their meals by one meal replacement. And that's something we might think about doing in future as well, because that immediate transition from, a formula-based diet with just vegetables to, out there in the wilderness with food again. I think that's really hard for people. That's definitely feedback we got from patients as well.
I think that's one of the differences with the new NHSE commissioning of the low-calorie diets. Is that right, Lucy, that they've actually mandated that you do that stepped approach, still using partial meal replacements?
Yeah, absolutely. So they have been much more prescriptive in the NHS LCD programme. So it is over that 4-week period, reducing one shake per week and replacing a meal. So it is really a very prescriptive approach. and having meal plans to support those meal introductions as you go as well. So yeah, and the more we speak about it, the more I'm starting to see how some learnings could be taken from both studies to get the full impact. And that's one of the key differences there.
Thanks, Lucy. Michelle, we've had a question come in. People would like tips on creating the session content structure. So can you talk us through what we did in Midas and what sort of content there was in the different sessions throughout the programme?
Well, I guess in Midas, we didn't do group teaching at all for the participants. It was very much a one-on-one, using the app to interact with the multidisciplinary team, and for the multidisciplinary team to interact with each other, which is one of its great functions. So we didn't actually do group sessions, but however, we did cover within the individual sessions, we obviously covered, the information about their diabetes and as Sarah says, the food groups, and also covered on some of the psychological issues. But I mean, sessions that would obviously be really, if you were doing group sessions, I think I was looking the other day at the, the NHS rollout, and certainly the Manchester-based one has got some great sessions, which are obviously covering, the diabetes, the clinical need, the dietary, what do they actually need to do and why. But, really importantly, and I think 60 or 70% of them were actually based on behavioural techniques and getting them, to think positively about themselves, and stress management, mindful eating, those types of things I think are really important. So you either use those that information as a group session, or you can teach people individually, which is kind of what we did in Midas.
Thanks, Michelle. So Basil, coming back to you, we've had a couple of questions come in around the safety. And one is around what sort of symptoms or adverse events came up during the Midas study. Was there differences between what came up in the low-calorie group versus the intermittent group, for example? Hold on, I think you're muted. Let me sort you out. Bear with me. There you are, Basil.
I'm not muted, Maya. Can you hear me now? Yeah. So I don't think that there were differences between the two groups. And in the whole study, there were 9 serious adverse events. 3 of them we thought were related to the intervention, and they were mainly related to gallbladder disease, so the development of gallstones and cholecystitis. But as far as I can remember, there weren't really differences between the two groups. The other adverse events were relatively minor, and which were observed in other low-energy diets, so constipation, headaches, feeling the cold, so relatively minor. And none of the including the adverse events, none of them resulted in patients withdrawing from the study. So they continued in the study, which is good.
So I think the mild effects were actually slightly lower in the intermittent than the continuous. But I guess the important point is because they are mild, they're not really affecting people's ability to do the diets. As you've seen, the continuous group did the diet, and so the results are the same. So there is potentially a slightly lower, those mild side effects with the intermittent, but they're probably not, that probably doesn't really matter.
Yeah, the key ones like gallstones, it sounds like.
Absolutely, totally right, yeah.
Okay. So we haven't quite found the solution for that one, which of course is well known with rapid weight loss.
Yes, exactly, yeah.
Lucy, just a quick, can I just say a quick word on the transition? Because, I mean, we talked about this a lot as a team. And so one of the things that we thought about is that the patients, the people with type 2 diabetes, do the continuous phase for a period of 8 or 12 weeks. And then an alternative would be that they move to an intermittent type of diet. We know that for the intervention in weight interventions, most interventions are associated with a rebound. So yes, people do well while they're on the intervention, whether these are drugs or dietary interventions. And then once they stop the intervention, the weight tends to accumulate again. So I think we need to think along the lines of having a long-term solution for people with type 2 diabetes. Because once they gain the weight again, that wonderful reduction in HbA1c just reverses. It comes back again. Their HbA1c goes up again. So we need to think about something that is doable in the long term. And of course, they can't stay on total diet replacement for the rest of their lives. So we need to think of something which is acceptable. So maybe a couple of days of total diet replacement and 5 days of a healthy Mediterranean diet.
Yeah, it's a really good point, Basil. And I think, weight regain after weight loss is obviously high on everyone's agenda, particularly when we look at commissioning these programs more widely, because we know that weight regain is an issue for a significant proportion of people. And what you'll see is what you're getting is a delayed complication risk. So you will be able to put off complications, and there will be cost savings for the NHS associated with that. But of course, what we all want to see is that the impacts that they've achieved on that lowered HbA1c and the reduced medication needs being continued long term. And you're absolutely right to do that. What we need to see is that we find approaches that can maintain the weight loss that was achieved in that intervention period. And I think there's huge potential for us as partners in the future to look at, are there the dietary strategies like intermittent fasting that can help that going? And what's the role in digital? So obviously giving people continued access to their app for self-monitoring, access to group forums. Obviously that comes with very little cost from a delivery perspective. And if you can keep somebody engaged, giving them very clear access to relapse programs, the potential to re-enroll on top-up modules to help them bring their weight back down, and explore things like intermittent fasting as a way of continuing, actually you could get a much greater 5-year, 10-year even weight reduction overall. And, we are just at the infancy of discovering the potential of these approaches in type 2 diabetes. We know they're effective in the short to medium term. And what we've now got to find, what are the key attributes in keeping that going long term? So I'm really glad you brought that up. There was one other question for you, Basil, that came in, which was actually about what did we do with medications? Obviously, you've already said 10% of the people that we had were on insulin. We had people on a variety of medications on the trial. What did we do to keep them safe, and what medications did we stop?
So the people who were taking metformin, we kept them on metformin. And I think the rationale behind that is that metformin is maybe a bit weight reducing, maybe weight neutral. It's a safe drug, it's a cheap drug, and it makes sense to keep people with type 2 diabetes on it. There's some good data on metformin, so we felt that we should keep those who were on metformin on it. There were some people who weren't taking any drugs, and in the continuous arm, we didn't put them on any drugs. We just introduced the diet and just monitored their blood sugars and only introduced medication when it's necessary. In the intermittent group, we dealt with it slightly differently. So we stopped all anti-diabetic medication that can cause hypoglycemia, so basically sulfonylureas. But we kept patients on anti-diabetic medication that are weight reducing or weight neutral, and those that don't cause hypoglycemia, so SGLT2. There were very few on GLP-1s from the outset, and DPP-4s, we kept them on those. For the insulin group of patients, for the 10% who are on insulin, we had a fairly complex regimen that we used to adjust the insulin treatment for these patients with a particular protocol, reducing their insulin doses on the days where they were using total diet replacement. So in the end, as I said in the results, although the HbA1cs in both groups were equal. 42% in each group achieved an HbA1c of 48. There were more people in the intermittent group on medication than in the continuous group.
Thank you. That was really clear and helpful. So, Lucy, I'm going to come over to you. A few questions have come in about what you do in hard-to-reach groups and perhaps people with low digital literacy to make sure that if we are seeing more and more digital programs, particularly post-COVID, that we're not actually marginalising people further or excluding certain groups if there is a level of low digital literacy out there.
Yeah, absolutely. And happy to jump in here and maybe give some of my experience and some of the results I can share from Oviva. So when you think digital, you think of a much younger cohort. You maybe think of a working age cohort that can access this. But actually our learnings are very diverse. We have a breadth of participants across all of our programs being able to engage in digital. And I think even the word digital can off-put some people, thinking you have to be digitally enabled, like myself at the beginning of this webinar this evening, not being able to get onto my internet. So I do think even the terminology digital can put people off. So much more of a different approach of our thinking really at Aviva is thinking of remote. So actually what offering and what tool of suites can we give someone? Have we got someone that is very tech savvy, very able to use different forms of app, whereas actually our app is a very straightforward tool of communication. If someone can take a picture on their phone, if they can send a WhatsApp chat, they can definitely communicate with the app that was used here in the trial, the Aviva app. Also to mention here that the digital offering is a great tool of self-tracking, being able to monitor. But if you don't have those tools to your hand with either the availability of a smartphone or the tech ability, realising that digital can encompass remote care as well. So telephone calls, being able to still have that one-to-one support. So throughout the trial, the digital tech enabled people to have a communication. So it was a platform of communication between the dietitian, between the nurses, the psychologists, the exercise therapists within the programme to communicate with participants at their own leisure, at the time to suit them. And when you look at kind of what historically we've been able to access within, you mentioned hard to reach groups, Lucy, and typically when you look at kind of engagement within diabetes in education sessions, you have a much higher uptake from women, where actually we've demonstrated that 57% of our attendees, and we looked at a cohort of 6,000 people, 57% were men. We had 34% over the age of 65. So if you flip that, we have a high percentage of working age people. And then looking at all areas as well of hard-to-reach groups, and with 22% of people attending our service actually as non-English speakers. So maybe when you look at digital for some, you think it can be a scary approach, but actually it's really widening the access. So people being able to, especially in this current climate, be able to access care and the support they need from the comfort of their own home. And I hope that answers your question.
It does. Thank you very much. And more widely, staying on you, Lucy, what do you think are the sorts of benefits to be had from implementing programs like these more widely across the NHS?
Yeah, absolutely. Just to go back to the NHS LCD pilot, it's actually one of the questions they're answering. So in the NHS LCD pilot, the key question they're seeking to answer is what approach suits people best. So they are comparing one-to-one support with group support. Originally, the plan was for that group support to be at a face-to-face format, but at the moment it is taking place of remote care. But they really are examining what approaches work best for people and with what demographics. So I think over the coming years, looking at what data we're going to get from the NHS LCD will really help support and prove that actually we need a suite of options. For some people, a group face-to-face is an ideal situation. For others, it's a daunting nightmare. So therefore, one-to-one support in a digital form is better suited. But we need to appreciate that different formats are going to really appeal to different people.
Thank you. That was really helpful. Michelle, coming back to you, how important do you think it is for us to have more access to digital interventions in this sort of during post-COVID world? Is it going to be more important, or do you think that role was set there anyway?
I think it's certainly COVID has made the NHS get much quicker at turning things into remote, and I think for a lot of people it is working very well. So I think it will. There'll be much more of it. I mean, clearly it's not going to be for everybody, as Lucy's already stated, and I think that's it. You know, I was looking earlier. Apparently, 10% or 90% of the UK population are on the internet. So 10% are, but you know that we're never going to have 100%. So we have to always have other options. But it's very important. We've actually just started running a trial, and certainly the COVID thing is definitely focusing people's minds on weight. We've never had so much interest from a weight loss study that we've advertised before. So I think this whole thing has shifted focus into an interest in weight management and particularly the remote delivery. So we're kind of ahead of the game with that. But yeah, it's not for everybody, and I think we're always going to have other options. Yeah.
Well, choice is always going to win over everything.
Exactly.
Isn't it? We can make sure that we're meeting people's needs and giving them the access that suits them and their ways of learning and getting there. So, Lucy, another one for you. There are a lot of questions, people interested in trying to build up these services locally. What would your advice be, or top tips, if somebody was looking to try and get some services going locally? Can you give some examples of where Aviva is perhaps operating these services, and how have we got over challenges locally? Sorry, there was a lot of questions. If you want me to break it up.
Where to begin? I suppose off the back of, I remember attending, I promise I'm not going off on a track of my past history, but I can remember attending Diabetes UK in 2018, and the take-home message from that was, from Direct, go out there, get commissioned, everyone should be doing this. But I think there's been a slow uptake, because actually diabetes has been seen, really type 2 diabetes that is, as a chronic disease that is managed and not necessarily treated, and that we could put something into remission. So I think the more the media has taken on with really getting this message out there of the Direct trial, the more confident you're going to find people are in this approach. Historically, people have seen it maybe as a diet that's a quick fix, it's a rebound, people regain weight. But actually, we're getting more and more evidence to show it's not that. If we can initially get someone's weight, we can really get someone's body into remission within the realms of maybe 50% of those losing the weight. And then it's all about being able to maintain that weight and really looking at Direct, looking at Droplet, looking at how we can support behaviour change post those interventions, is building that evidence base so people are much more confident in this approach, and realising that there is actually space within the treatment of type 2 diabetes for this to be listed as a treatment. And so I do think going forward, if you have had difficulties in the past with commissioning, it's looking at what timeline, when was that? Has it been post NHS LCD going live, where there has been a huge amount of interest invested nationally into this? So I think going forward, it will be a much easier sell to commissioners, to your local peers, to your local networks to try and get this into practice. Following from Sam, and where we're really short on time, but if anyone does, who've asked those questions, if they do have any and they're wanting to seek more support in how to get that commission, then please do contact me afterwards, and I'm more than happy to share some of our experience and success in the area of NHS LCD that I can help support you on.
Thank you, Lucy. And one bit I would add to your answer there is actually money matters. So remember, when you are pitching, when you're putting in a business case, we need to be putting in what are the cost benefits of services like this, because there are benefits for in-year savings when you achieve a big reduction in HbA1c and medication needs. And actually including that alongside all of the patient benefits really makes a big difference. We are massively running out of time. I do not want to miss the opportunity to say a huge thank you to my panel speakers who've given up their Thursday evening to talk to us about the Midas team. And the Midas trial, and to Lucy as well from the Aviva team. I hope you agree. It's been a really interesting evening. There are so many messages on our Q&A that we haven't got round to, but we will send those out on Monday with some answers to make sure that all of your queries have been got to, and you can access the recording of tonight as well. So a huge thank you for joining us. I hope it's been interesting. Please do keep those questions coming on the Q&A until the end, and we'll make sure that we come back to you. And we look forward to updating you with further Midas studies in the future. Thanks very much, everybody.